interesting episode of the 4D, which is the detailed discussion and dialogue in Indian diabetes. I am really honored today to be a part of this. Thank you, IJCP, for having us here. And more than anything else, I'm really grateful to be here present today with none other than Dr. Sriram Sankar. I guess everybody has heard him, met him. So it's a great pleasure to have him here with us. Well, our topic for today, this is our 7th episode of 4D, and what we are discussing over here is body weight and its role in type 2 diabetes and CVD. Well, why is body weight becoming so important? Well, more and more we are recognizing that weight ultimately is the upstream problem that finally results in a number of downstream diseases, the most common, the most deadly of which being diabetes and cardiovascular disease. As we're all aware, well, I'm wondering in this audience, how many of us are truly aware of whether we are classified as overweight or obese for that matter? So at the start of this show, I would want everybody one time to check their BMIs because as we are aware, as per the South Asian cutoffs, the BMI cutoffs for overweight and obesity have been decreased. We are now classified as overweight if the BMI is 23 to 24.9. And at more than 25, we are already put into an obese category. And the reason the BMI cutoffs have been decreased for our population in particular is because the complications of weight appear that much earlier amongst us Indians, especially. To shed some more light on this, I am so pleased to have Dr. Sriram Sankar as our presenter today. Dr. Sankar, welcome to our show here this evening.
Thank you, ma'am.
And so just to very quickly introduce Dr. Sankar, well, Dr. Sankar is not only restricted to diabetes, of course, he is a physician, diabetologist, but he has been a teacher par excellence. He is part of the faculty for the DNB program, the medicine program, and the course coordinator at the District Hospital of Palakkad. Also part of the faculty for the internship program, also for the same hospital. He's had many great hospital committee appointments as well. A nodal officer for NCD's control program, for the National Viral Hepatitis Control Program, for the Stroke Identification, Rehab Awareness and Stabilization Program. So, sir, it's great to have an all-rounder available with us today. Welcome to our show, and please, let's have you talk on our topic today, which is body weight with diabetes and CVD.
Thank you, AGCP, for giving us a wonderful topic that is body weight, diabetes, and CVD. And thank you so much, Pia Belani, ma'am, for this kind introduction. I'm really honored to have you to moderate this session. So, body weight, a risk factor for diabetes and CVD. We all know that these are all three important things, and actually, as a risk factor for each other: body weight, diabetes, and CVD. So, to start with, obesity in India. We'll just see how obesity is simply a complex condition of increased subcutaneous as well as visceral adiposity. It's associated with adipose dysfunction and insulin resistance. These are the two important factors that actually are the risk factors for our diabetes as well as cardiovascular disease. In urban India, it's almost 3 to 4 out of Indians are considered to be overweight. These are actually data from two important things. One is an ICMR INDIAB study as well as National Family Health Survey conducted. So based on that, urban India is considered to be overweight. 3 out of 4 Indians are considered to be overweight. And prevalence of abdominal obesity was found to be 40% in women and 12% in men. Studies has again shown that 5 to 6 out of 10 women between the age of 30 to 49 are considered to be abdominally obese. And the association of abdominal obesity in women is stronger with older age group, urban residents, wealthier sections, as well as non-vegetarian. These are actually the terms straight away taken from the National Family Health Survey. But one important thing is the urban-rural divide in India is actually reducing a lot. India, we cannot put it as a developing country. It is almost a developed country now, and the urban-rural divide is actually reducing. So is the incidence of the diabetes as well as obesity. So these are actually database. Most of the studies based on 2019 to 2021, this pre-COVID time. Both National Family Health Survey as well as ICMR in-depth studies. Indians are at increased biological risk of CVD, like ma'am in the introductory speech has rightly pointed out. Indians are always have a higher risk of CVD, whether they live in India or outside. So, Indians are known to have the highest cardiovascular disease or a cardiocoronary artery disease rates, and the prevalence of CAD in Indians living in India is 21 percentage, 21.4% for diabetics and 11 percentage for non-diabetics. That is like 10. If you see 10 patients of diabetes, there's always two patients have an increased risk of CAD in India. The prevalence of CAD in rural parts of the country is nearly half than that of the urban population. But again, I insist that the urban-rural divide is actually coming down, and the risk factor, the prevalence of CAD in rural part might be much higher than what's been reported. Diabetes in India, it's around 77 million people above the age of 18 years are suffering from type 2 diabetes, and nearly 25 million are pre-diabetics at a higher risk of developing diabetes in the near future. So pre-diabetic age group, a pre-diabetic group is almost one third of what the diabetes are. So a total of about 100 million people are either diabetic or pre-diabetes. Adults with diabetes, definitely we know that they have a 2 to 3 fold increased risk of heart attacks as well as strokes. So the CV risk is always high in adults with diabetes than the non-diabetics. Linking obesity, diabetes, and CVD, like all the previous studies have shown up. These are data actually from a UK biobank cohort study. We know that obesity with diabetes always have the highest risk factor for CV risk. Even obesity, even diabetes with the overweight category will have a higher risk compared to a non-diabetic or a non-obese person. So these are all data which are already we all know, but these are like documented data, evidence available for the talk. So, linking obesity, diabetes, and CV risks, we all know that obesity will be having a baseline inflammation, lipotoxicity, or leading to insulin resistance. And insulin resistance finally would lead to two major mechanisms. One is development of diabetes, and the other one is the accelerated atherosclerosis, all leading to the increased CV risk. So, how we prevent this? Prevention, obesity, diabetes, CV risk. The common thing in the preventive aspect is lifestyle modification. We all know that lifestyle modification plays an important role in all the three conditions. And rightly pointed out things like a 40 minutes exercise regularly, at least 5 days a week, will make a whole lot of difference in all three conditions. Then the next thing would be diet. A healthy diet, cut down on sugars and saturated fat, avoid tobacco. All these things are the common preventive aspects for obesity, diabetes, as well as coronary CV risk. There might be few other things to add on. Maybe a television time or a screen time, limiting screen times might make a difference, but screen time is slightly controversial because any profession we take, any profession, students, teachers, everyone, all are glued to screen for some or other reasons. So mainly it would be a lack of exercise or a more sedentary lifestyle that would be an important risk factor. Screen time definitely would contribute to obesity if we are not exercising enough. Other things would be to know our blood pressure, know our lipids, know our sugars, and most importantly, like PMM has already pointed out, we should know our BMI, we should be knowing our waist circumference. All these things we should be aware of altogether. So avoiding, so the basic things would be a healthy lifestyle modifications, including exercise, diet, eating right, and cutting down on screen time and avoiding tobacco would be the important preventive aspects. Therapeutic strategies, there are a lot of FDA approved drugs, phentermine, diethylpropyran. These are things which we are not been regularly been using. The other approved drugs for long-term use include orlistat, topiramate, bupropion, etc. They can be a good anti-craving drugs. The other approved drugs include liraglutide and semaglutide. They are GLP-1 agonists, which has definitely been played a definite good role in management of obesity. So the initial thing, orlistat, topiramate, bupropion, liraglutide, these drugs actually would reduce our craving, would help in reducing the weight. But most of the case, our diabetic patients, usually elderly patients coming to us, might have a problem because most of them won't be eating much now. Once they have set into a certain weight limit and they've already been diabetic for quite some time, they already have got some complications, might be having osteoarthritis, other things which actually prevent them from doing for going for the lifestyle modifications which we have already told. So these are people who might need some other method to actually reduce the weight. So though not approved by FDA for the weight reduction aspect, but we have wonderful drugs like SGLT2 inhibitors, which we have on our own evidence on have shown that like they've reduced the weight to a very good extent, especially in the initial part of management. So the anti-diabetic medications do play important role, though the GLP-1 agonists also have the same role. But SGLT2 inhibitors, through its different mechanism, through the reducing, not only reduces the sugar but also reduces the weight. DPP4 inhibitors, again, they are actually weight neutral drugs. So one thing we can put in like this, that they are at least weight neutral and they are not weight gaining drugs. So DPP4 inhibitors being weight neutral drugs by reducing the diabetic part, SGLT2 inhibitors by reducing the weight as well as the diabetes. GLP-1 agonist, which we have already discussed, has got a great role in reducing the weight and has been FDA approved. Heart failure. So SGLT2 inhibitors has found use in most of the conditions, most of the complications of diabetes. And one important thing is the heart failure. It has got a role in both heart failure with preserved ejection fraction as well as reduced ejection fraction through multiple mechanisms, including reducing the oxidative stress, inflammation, fibrosis, myofilament stiffness, and a whole lot of mechanisms. They have got a important role, and there are umpteen studies which had actually proven that SGLT2 inhibitors has got a definite role. We have seen cardiologists prescribing SGLT2 inhibitors like enalapril or a beta blocker in most of their prescriptions. So SGLT2 inhibitors has actually found a permanent place in the cardiology management of things. Evidence-based studies, like it's a 24-week international multi-center randomized double-blind parallel group placebo-controlled studies. SGLT2 inhibitors, as we all know, will reduce blood sugars as well as HbA1c. That's a proven fact. The other advantages would be the reduction of body weight as well as systolic blood pressure from the baseline over 24 weeks regarding the body weight and around 8 weeks for regarding the systolic blood pressure. So all these things add to the advantage of preventing cardiovascular risk. So SGLT2 inhibitors actually change the way obesity, diabetes, cardiovascular risk. So this would be a one-time solution for all these things together through multiple mechanisms. So how will we place SGLT2 inhibitors and DPP4 inhibitors combination? So as I had initially told, SGLT2 inhibitors definitely has got whole lot of advantage through the multiple mechanisms which we have discussed. especially in reducing by mainly by reducing the weight. DPP4 inhibitors will just add on to the thing by stabilizing the sugar values. So a combination would have a multiple advantages, one being a weight neutral drug and one being a drug which can reduce the weight. So a combination will be of much use because it acts through two entirely different mechanisms. So not only by stabilizing the sugars, but also by reducing the body weight. Other thing will be the patient compliance regarding this combination would be because it reduces the pill burden, as well as we all know that the combination drugs are quite cost effective than being taken separately. So a cost effective reduced pill burden makes this combination a more patient compliant drug and add on to our advantage. So to summarize our discussion, India is actually fast catching up as a developed country, but also as a obese country. So the risk factors which we are going to encounter will be much higher than this thing. All the data which we have discussed are all like pre-COVID times. So the change, the way people are working after the COVID era has changed. The sedentary lifestyle has actually increased. The number of diabetics and the obese people would have definitely increased this thing. The basics pathophysiology we had discussed, and the prevention strategies would be simply the basic would be exercise, as well as exercise, diet, and cutting down on tobacco and all these things. We have the approved drugs and how SGLT2 inhibitors as a drug had changed the way we look at the all these three risk factors: obesity, diabetes, as well as CV risk we had discussed. So I just pass it on to ma'am for proceeding with the further.
Dr. Sankar, thank you for enlightening us about the problem and more than that, about giving us the solutions that are available to us as well. Because today, with the kind of SGLT2, DPP4 inhibitor combinations that we have available, well, I think the good news is that here we have two drugs that work with superior efficacy, very safe, CV safe, renal safe, hypo safe, weight wise also benefit safe from that perspective also, giving us sustained results in with a symbiotic way of affecting the, taking care of the pathophysiology and improving compliance as well. And finally, as I would say it in a sasta way also. So I always say superior, safe, sustained, symbiotic, and sasta. I mean, that I think is what this combination is about. Now, a few questions that have come up for you over here, Dr. Sriram. We are thin, fat Indians. Basically, weight is on the lower side. So then, in that case, how does weight loss impact insulin sensitivity, and lower the risk of diabetes and cardiovascular complications?
Okay, like if we just take BMI as a cutoff for obesity, we might be thin fat people. But like if we really take waist circumference and waist strip ratio, we might not be really that thin.
Right.
So that check actually changes the picture on how we approach things. So what I feel like, it's we are Indians are not exactly thin fat, rather we are obese to a certain extent, but it's the way we approach the obesity. So we take up waist circumference or waist hip ratio, the data is much high, and that's also been actually come up with most of the studies also. So but definitely by reducing the weight, it's not just reducing the weight, but actually by increasing the insulin resistance. So that's the angle which helps in reducing the diabetes risk, and again by reducing the insulin resistance, I mean rather increasing the insulin sensitivity, definitely through all the mechanisms which we had discussed, we will have a reduced CV risk.
Right. So I think it's the visceral adiposity primarily that is being taken care of
Yeah.
in the weight loss. So you were talking about BMI. So do you believe that now BMI is a good measure for body weight? I mean, that's the most commonly used research tool for that matter in assessing the risk for diabetes and cardiovascular disease. Do you think we need to move on now from that point of view then?
Yeah, BMI would be a globally accepted tool, but just BMI cannot be a thing for all the risk factors for assessing all the risk factors. So, rather, waist circumference or a waist hip ratio would give a better picture on that rather than the BMI. So, BMI alone cannot be there, but still, like our obesity, like ma'am, you had already pointed out, like our BMI cutoff has actually reduced. Now
Reduced.
we are obese if we are our BMI is more than 25, so
Right.
that would get us to a better picture on things, but still
True.
BMI is not a complete
Not it.
solution for all the
Correct. Right. So I think that you bring about a good point over there, Dr. Sriram, that the waist circumference, 80 centimeters in females, 90 centimeters in males. So everybody, besides calculating your BMI, look at your waist circumference. So waist circumference is also, because for that matter, inch loss in itself contributes towards being a positive health marker as compared to weight loss alone. So that's another very important factor to understand, that for us Indians with a central obesity, it is that inch loss also that is really helpful. Dr. Sriram, do you believe that there are regional and global variations in the prevalence of diabetes and cardiovascular diseases? Are they linked to differences in body weight and lifestyle as well?
Like there are always the regional differences are there, but Indians are supposed to have a higher CV risk, like
Right.
we are discussed in the slides, but within India there are always a difference, especially regarding the obesity, because the one thing I would point out, like there's the urban areas or states where the urban rural divide is much less, there are always the risk of higher obesity, higher CV risk, higher diabetes are all there. I, I work in a place in Kerala where it's a rural setup rather than an urban setup. Palakkad is a small town as such, but still there might not be much of a difference, because here in studies conducted here, like it's found that it's much close to the all India data. So it might not be much of a difference with the obesity as such, because maybe we are genetically more prone to diabetes.
True.
That's a thing which we need to think of.
Do you think there's a gender divide, also gender variation in, especially in small areas like yours as well? Females more than males. Do you believe that's also happening? Or you feel it's roughly equivalent?
No, there is definitely a gender this thing. Females have a higher this thing of incidence of obesity in any part of the world, rather than any part of India at least. And the
Yes,
basic thing would be the lack of exercise, which I would
correct.
put in, like this lack of exercise, lack of awareness of exercise, that's
Yes.
among the women, that has increased this risk.
Right. And also, I think women, do not see themselves probably as important enough to get to the doctor. They put themselves a little on the back burner. So there's a little bit of, I think women are given a little bit of a status, I mean, from that perspective, in terms
But
in terms of,
rather in my area, what I would put it in a slightly different this thing,
really,
because
okay,
in our OP, like in a government setup OP,
yes,
like I've seen more women who do a correct follow up. They do the sugars proper. They do the A1C proper. They do the
right,
follow up much better than
right,
the male counterparts.
right.
But definitely there is a gender
Yes.
divide.
Right. And hopefully the rest of India can follow Kerala's example on that front also as well. That would be a good place to be. So, Dr. Sriram, do you feel, what is the evidence today that is supporting the CV and metabolic benefits of this combination of the dapagliflozin plus the sitagliptin? Is there evidence behind all of this? Is the next question.
Weight reduction has got multiple advantages. Definitely, it has got multiple advantages, and a reduction of weight has always proven to be a big advantage in reducing the severe risk through multiple studies.
Yeah.
So we all know that dapagliflozin in its initial phase will have a definite advantage in reducing the weight. at least 4 to 5 percentage of reduction of weight. So that can just be added on to our multiple evidence on reducing the severe risk. A combination of DPP-4 inhibitors, like rather than adding an insulin or a sulfonylurea, which might actually increase the weight. So comparing to these drugs, definitely an add-on with the DPP-4 inhibitors will have a definite advantage. So combining all these things, there's definitely and this combination will have a definite advantage in reducing weight and reducing the severe risk.
Right. And I think there is now so much data as well, right? I mean, we have with the DAPA HF trial, the Deliver trial, all of so much, the CVOT trial that is there as well. All of that telling us that there's great data to tell us that there is CV risk reduction, heart failure risk reduction with the use of these drugs. And sitagliptin, of course, has proven itself to be neutral from a CV standpoint also. Finally, how do you believe that this combination, DAPA plus CETA, how does it affect insulin sensitivity, and how does it reduce the risk of type 2 diabetes and cardiovascular events? That's the last question on our list for today.
So the simple thing is reduction of weight is
Yes.
one advantage, and like you had already pointed out, like through multiple studies, like as SGLT2 inhibitors has got an advantage in most of the diabetic related complications, whether it is a CKD, whether it's a heart failure, all these multiple complications. SGLT2 inhibitors has got a definite role. So as like we had previously discussed, being reduced pill burden, a better compliance, and uh, cheaply available. So
Right.
sasta, but the
Yes.
term you had rightly pointed out. So that makes it much accessible for all the patients across the segment, and
Yes.
that has got a definite advantage in reducing the severe risk throughout.
Right. In your practice, Dr. Sriram, do you find that there are patients, this is just your personal opinion, where you might not be starting any kind of patients? Of course, I mean, the ones which are very, very uncontrolled, that's another story. But for the regular patient, do you believe that there are patients who should not be on this combination?
Women who had increased risk of has history of recurrent UTIs, because we know that SGLT2 inhibitors has got a less than 5% risk of UTI, though we all explain regarding the risk of UTI, vulvovaginitis, all these things before starting them. The other thing is chance of euglycemic ketoacidosis. These things we had seen in much cases. These are two conditions which I would be hesitant to
Correct.
start with. But all other conditions, there's nothing which we should be holding on
Right.
this SGLT2 inhibitors or this combination.
Right. No, so I totally agree. I think in this day and age, when we are trying to, what is our purpose ultimately as doctors who are managing patients with diabetes? Our goal really is finally to prevent the micro and macrovascular complications of diabetes, to basically give the patients a good quality of life and to improve survival. That is what our goal is at the end of the day. And I think from that perspective, I'm actually looking now for reasons not to put the patients on these kind of drugs, especially the SGLT2 inhibitors. I think all of us have to look for that, because finally we have tools that are giving us not only glycemic benefits, but those extra glycemic advantages as well. And this combination does it in such a superior way. So I think for all of us who are managing diabetes, understanding how these drugs work, these combinations especially, which improve compliance, improve pill adherence also, I think is so, so important to know. Your last words for this session, Dr. Sriram, before we can close?
A combination of SGLT2 and DPP4 would give a lot of it's an answer to all the three problems the title has put up, like severe risks,
Yes.
diabetes, as well as obesity. So these are things which we are going to face in future, because India is fast developing. It's actually gaining weight. India is actually gaining weight. So
That's true.
these are things which we, as people practicing diabetes, people dealing with diabetes, are going to face. So this has got a definite advantage in countering this, and will be a good arm in dealing with all these things. So we hope to have like a better improvisation in these SGLT2 inhibitors with more importance to the weight gain will be a good advantage for all people who practice diabetes.
Right. And I think thanks to Indian pharma, we have this available economically, which is such an important factor now for our population as well.
Exactly.
So thank you, IJCP. Thank you, Sun Pharma, for having this show. And with that, good night to everybody. Thank you, Dr. Sriram, from my side also. Good night.